Hello. So in this talk, I shall be discussing the basics of management of fracture supracondylar humerus in children. I shall be discussing the classification, the evaluation, and management in the coming few minutes. So firstly, regarding the classification, so it is always useful to classify a supracondylar humerus fracture according to the direction of displacement, because this gives us an idea about the mechanism of the injury and also tells us something about the reduction maneuver that is to be employed in order to reduce that particular fracture. So we all are aware that majority of the supracondylar humerus fractures, these are extension type where the distal fragment is displaced posteriorly. These are further subdivided into fractures with posteromedial displacement, which are more commoner than fractures with posterolateral displacement. Flexion type fractures where the distal fragment is anteriorly angulated or displaced are extremely rare. We are all well versed with the Gartland classification of supracondylar humerus fractures. So type 1 fractures are undisplaced fractures. Type 2 fractures are green stick fractures where the anterior cortex is fractured, however the distal cortex is preserved. And type 3 are completely displaced fractures. However, there have been a few later additions or modifications to the original Gartland classification. So type 2 fractures have been subdivided into type 2A, that is fractures with pure sagittal angulation, and type 2B, where there is angulation in addition, and additionally there is malrotation. Also in 2006, Lech described a type 4 fracture, which is a fracture with multidirectional instability. Finally, there is the Bahk classification is extremely useful to identify the pattern of the fracture. So a typical supracondylar fracture is transverse in both the sagittal and coronal planes. However, there can be a few atypical fracture subtypes. So in the coronal plane, you can have lateral oblique fractures, medial oblique fractures, or high fractures. In the sagittal plane, you can have posterior to anterior fractures, that is sagittal oblique fractures. The importance of identifying these atypical subtypes is that these are many times difficult to reduce. These are unstable, and many times you may need to modify your pin configuration in order to stabilize these fractures. Coming to clinical evaluation, so every child who presents with a supracondylar humerus fracture should undergo a thorough neurovascular evaluation. A quick neurological examination to test the integrity of all three nerves can be done by asking the child to demonstrate rock, paper, and scissors and perform the OK sign. So this will tell you that all three nerves are working. Additionally, keep a close watch for compartment syndrome. In children, compartment syndrome or impending compartment syndrome can be identified by looking out for three A's, namely anxiety, agitation, and increasing need for analgesia. Additionally, you have to look for an ecchymosis or pucker sign. The presence of an ecchymosis indicates that there is a significant soft tissue injury, and it also indicates that the reduction may potentially be difficult. And the site of the ecchymosis, it tells you about the location of the spike of the proximal fragment. This is important if you are planning to perform an open reduction, if you need to perform an open reduction. Next, coming to radiological evaluation. So in type 1 fractures, many times the fracture line is not seen on day 1 radiographs. And here you have to rely on the fat pad sign. So the presence of a posterior and anterior fat pad sign indicates an intra-articular hematoma, which in turn is a surrogate sign for a type 1 fracture. Also in type 1 fractures, you have to closely look out for medial column comminution because these fractures are likely to collapse into varus malunion. In type 2 fractures, in type 2A fractures, which are fractures with pure sagittal angulation, you have to look for the relationship between the anterior humeral line and the capitulum. So if your anterior humeral line is passing through a part of the capitulum, then these fractures can safely be treated with a cast in situ. However, if your anterior humeral line is passing anterior to the capitulum, that is your angulation is more severe, then these fractures need a close reduction and K-wire. Malrotation in a type 2 fracture, that is, type 2B fractures can be identified by noting the differential width of the fracture fragments of the proximal and distal fracture fragments at the level of the fracture. And these fractures are typically unstable and therefore they must be treated by close reduction and K-wire fixation. Finally, coming to treatment of type 3 fractures, and this is classically done by closed reduction, K-wire and cast. This is the gold standard for treatment of type 3 fractures and also for selected type 2 and type 1 fractures. So here, different types of OT setups can be used. What I personally prefer is for the older child, I prefer option 2, that is placing the elbow on a sidearm board. However, if the child is younger, then I prefer to push the child to the edge of the table, place the affected elbow on the radiolucent part of the table, and so the C-arm comes in from the opposite side. Coming to the steps of reduction, so the first step is traction applied by the surgeon, whereas the assistant applies counter traction. This step is extremely important to disimpact the fracture fragments. Sustained traction should be applied for some time before proceeding to the next step. The next step consists of correction of coronal angulation. So usually these fractures are in varus, and therefore you need to give a valgus stress to the fracture site in order to correct the coronal displacement. The third step is correction of sagittal displacement, and for this the surgeon applies thumb pressure on the olecranon, and while applying sustained pressure, he hyperflexes the elbow in order to bring about reduction. The last step is locking of the reduction. So for fractures with posteromedial displacement, this is done by pronation of the elbow, whereas fractures with posterolateral displacement, you need to supinate the elbow. After having achieved the reduction, you need to check the adequacy of the reduction under image intensifier. So for the coronal plane alignment, you obtain a Jones view and check the Bowman's angle, whether it is in the normal limits of 70 to 75 degrees. Additionally, you obtain pillar views by taking oblique images. And for the sagittal plane, you need to rotate your shoulder externally. Or you can, invert your C-arm and obtain a good lateral view. Finally, coming to fixation. So fixation for typical fractures is done, or it is recommended that only lateral K-wires be used for the purpose. Out of these, the inner wire, it passes through the olecranon fossa, and therefore this wire, as you can see, has a 4 cortex hold. Therefore, this is an extremely good hold. The outer wire, it is a pillar wire. Additionally, in between the inner and outer wires, there should be good divergence and there should be spread at the level of the fracture site. You may add an additional wire in between if you feel that the fracture is unstable at the insertion of after the insertion of 2 wires. In the sagittal plane, your wire should extend from slightly anterior to posterior. You may need to modify your pin configuration in certain atypical fractures. So for medial oblique fractures, you will need to put medial wires. For high fractures, you will need to put intramedullary wires. And for sagittal oblique fractures, your wire configuration in the sagittal plane will have to be from posterior to anterior. So to conclude, careful clinical and radiological evaluation is important to differentiate typical from atypical fractures. Type 1 fractures, majority of these are treated conservative except for the rare exception of fractures with medial column combination. In type 2 fractures, close reduction and K-wiring is done for fractures with excessive sagittal angulation or with malrotation. And in type 3 fractures, close reduction, K-wire and cast is the gold standard of treatment. Thank you.